Thanks. It's a pleasure to be here with you this afternoon. To my shame, this is actually my first ever visit to Montreal. But at about 10:30 last night, when I looked out of the window of my bedroom on the 22nd floor of my hotel and I saw students protesting in the street, it felt as if I barely left London, because we have very similar scenes there. I'm not going to get drawn into a comparative discussion around which group of students have more to complain about, because there were some major educational reforms going on in England as well. But felt good to be home last night. Yeah. So I'm going to talk about a couple of studies that I've been fortunate enough to be involved with over the last sort of 7 or 8 years. And I'm going to relate some tales of the field, and I'm going to sort of set up this duality around the art and the science of studying how hospitals organise for quality. And it's important to point out at this stage, these two studies are focused just on acute hospitals. I'm then going to compare the research designs, methods, analytical approaches from these two studies. They're both cross-national, multi-level studies of how hospitals organise for quality, and then explore some implications of the choice of our research approaches, methods, and methodological challenges. The other thing to note is that, as well as the studies only being in acute hospitals, these are very applied pieces of research. They've both been set up explicitly to produce tools, heuristics, ways of helping practitioners reflect on the way they've organised their hospitals in terms of quality and to help them to improve them. But as I'm sure many of you know, the title of my talk, Tales of the Field, comes originally from John van Maanen's 1988 book, where he's surveying the different ways in which ethnographers write about culture and the way in which they represent their fieldwork findings. Fantastic book, if any of you haven't read it. It's also eminently quotable, as all of his writing is. But I picked out this one because I am a sociological field worker. He was writing in 1988, so I hope things have changed a little bit. But he said, sociological field workers produce texts that seem restricted in range, full of jargon, stuffed with remote facts, as if to satisfy some fetish or documentation or legitimization. They exhibit little interpretive nerve. What I hope you'll take away from my presentation today is that in terms of the two studies that I'm going to talk about, we have at least shown some nerve in undertaking them, but I'll leave it for you to judge quite how successful we've been with the interpretive bit. So in his book, John van Maanen talks about different voices for the ways in which ethnographers talk about their fieldwork. And for those of you who know it, the main ones he talks about are realist, confessional, and impressionist tales. But he also touches on critical, formal, literary, and jointly told tales. And then at the end of the book, he sort of throws in this additional one, what he calls the fieldwork for a fee bunch, ethnographic writings that flow from the applied stream of social science research, such research as I do, and practice would include hired hand tales in which field workers study and report on social impact and fix-it questions at the request of others. I want to reframe that slightly because I think he was writing in 1988, and I think now in 2012 we can probably reframe that as translational research and trying to translate research into outputs with relevance, utility, and value. So what these two studies are both about is of taking this research practice continuum and trying to fold in both ends of that so we get closer to research into policy and practice, more practicing researchers and more researching practitioners, the concept of actionable knowledge. So those are the outputs that we're trying to get to in both of these studies for practitioners. So we started the first study in around 2002, 2003, and at that time we felt there were various gaps and limitations in the studies of healthcare quality, a lot of this building on Andrew Pettigrew's work. But most of the research up to that date had been gazing down from the sky rather than searching on the ground, the point that Jean-Louis was just making, that we'd be looking for statistical trends from on high around quality rather than getting really deep and close into microsystems and the nuances of quality and quality improvement. Often we're searching for variables rather than processes, so we're looking for cause and effect relationships rather than the dynamics of change. And as Jean-Louis just mentioned, this notion of multi-level wasn't really there in the research. We tend to focus either on the macro or the micro, sometimes the meso, but we wouldn't look at them together. Mostly there was a focus on clinical and technical factors and those types of processes to the exclusion of human and organizational processes. And as you'll see in a moment, this focus on human and organizational processes is something that we really tried to bring to our studies. And often also the research at that point had been descriptions of the what rather than explanations of the how or the why. And another book that I like to go back to a lot is Pressman and Waldowski's book on implementation from the 1970s, actually based on research they did in the 60s around the Economic Development Agency in Oakland in California. But they talk about if you just focus on the what, you're leaving out the detours, the blind alleys, the discarded hypotheses, the constraints tightened and loosened, the lumpy stuff of life, in favour of a pre-digested formula consisting of a ranking of objectives, a considering of alternatives, and a criterion that chooses amongst them. So we were really interested in getting much closer to this lumpy stuff of life. And that's why the organisational and human dimensions are so important in our studies. And as we wrote in the book that emerged at the end of the first study, quality is not just a method, technique, discipline, or skill, but a human and organisational accomplishment, something that is constructed by people in their everyday actions and interactions with and for each other, a social process. So we're interested both in the science and technology of improvement, where up to that point I think most of the research had been, but also on the right brain side, the sociology and organisation of improvement, so organisational culture, language, cognition, identity, those types of issues. And it's not about saying that one is more important than the other, but just that we need to study them together. So I hope you can say it's good, you can. So this is a sort of brief overview of the two studies that I'm going to give you a whistle-stop tour of and then reflect on the implications for where we are in terms of studying quality. So the first study is Organising for Quality, took place between 2003 and 2005. And this is the one that I'm going to sort of frame as being around the art of quality improvement research. And the second is Cahspr, which stands for Quality and Safety in Europe by Research. And that began in 2010 and is ongoing. It's a 3-year study. We're 2 years in. We've just finished the field work, just about to start the cross-case analysis, and it runs until next spring. And that's the one that I'm going to sort of frame as being around the science. And I've just listed here some of the key differences between these two studies. So in terms of funding, Organising for Quality was very much on a shoestring. It was funded initially by a small amount of funding from the Nuffield Trust, which is a policy think tank in London, and then later on in the research, the RAND Corporation, who are Peter Mendel, who's one of the co-authors, works for the RAND Corporation. They put in a little bit of extra money at the end, but it really was a very, very small budget, and most of the field was very opportunistic. The Cahspr study, as Jean-Louis mentioned, very well funded, is €3 million. The researchers on the Organising for Quality work were basically myself, Paul Bate and Peter Mendel, coming very much, well, pretty much from the same disciplinary perspective, and in Paul and my case, coming to the US for conferences and then tagging on a couple of extra days on those conference visits and going off to one of our field sites. The Cahspr project, 16 women, 6 men, embedded in local contexts, very different disciplinary perspectives across the group. The underlying approach to Organising for Quality, I think it's fair to say, was that we were making it up as we went along. We were all interested in this, and we were just doing our best to find little bits of funding to do a little bit more field work. Weren't quite sure where it was all heading, but we wanted to just try and address some of those deficiencies in the research base that we saw around existing quality improvement research. The Cahspr project has a very strict protocol and, importantly, someone to report to, and there is a lot of reporting to go upwards to the EU for this type of project. The methods for Organising for Quality, about 150 interviews spread over 7 hospitals at the meso and the micro levels, a little bit of observation spread over 18 months. In Cahspr, we've just finished the field work, something like 400 interviews, 796 hours of observation, 180 meetings relating to quality improvement in 5 countries, undertaken over 12 months by research teams embedded in each of those 5 countries. The case studies in Organising for Quality were 7 hospitals, 1 in Holland, 3 in the UK, and 3 in the United States. And we found them by asking people we knew and liked about where they thought there was some interesting research, interesting quality improvement work going on. So we asked people like Don Berwick in the States, and we asked people like Paul Bertelden, Helen Bevan in the UK, etc. For Cahspr, we've selected the 10 hospitals, 2 in each of the 5 countries, using 10 process and outcome indicators, and then selected 1 high and 1 low performing hospital in each of the countries. As I mentioned, Organising for Quality was very much focused just at the meso and micro levels. We sort of, towards the end of the research, tagged on a little bit of sort of macro work, but there was very much an afterthought, whereas Cahspr has begun with all 3 levels, and we've given them equal attention. The conceptualization of quality in the Organising for Quality work was a very broad and loose idea around quality service improvement, whereas in Cahspr we've taken the conceptualization of quality that's current in the NHS around clinical effectiveness, patient safety, and patient experience. In terms of organising for quality, it was all very inductive. We went in very open-minded. It was about observation, looking for patterns, and I'll show you some of those in a moment, coming up with some tentative hypotheses, and then hopefully moving towards some theory. Whereas the Quasar work has been much more deductive. It started from the results of the organising for quality work. We've been testing out some hypotheses through our observation and field work, and hopefully coming to some sort of adaptation and confirmation at the end of that. And the spirit of the endeavour, which I think is important, the organising for quality work, very much a sense of adventure, open, not empty-minded as we went into the field work, very exploratory. Whereas the Quasar project has a clear sense of purpose and clear objectives, and I'll show you some of those in just a moment. I just wanted to flag this up. How do you make sense of all this fieldwork data in a way that's going to be useful for practitioners? That was the challenge for us in both of these studies. And of course, we drew on Anne's 1999 typology of the way in which you make sense of process data and the trade-offs you have to make between these three attributes of accuracy, simplicity, and generalizability. And I'll come back and show you what we made of that in a moment. So this is the Organising for Quality work, 2003 to 2005. We wrote up a book about it at the end. There's also, if you're interested in finding out more, because I'm not going to have a great deal of time to go into detail today, there's a free summary that you can download from the RAND Corporation website. So these are the organizations that were included: Cedars-Sinai in Los Angeles, Luther Middlefoot in Eau Claire, San Diego Children's Hospital, SSM Healthcare in St. Louis, which had just won the Baldrige Award at the time of the fieldwork, the Delft Hospital in the Netherlands, and then 3 hospitals in the UK, Peterborough, Exeter, and King's. I'm not going to go into too much detail around the methods, but these were in-depth case studies in the hospitals over 18 months, mainly qualitative, but we also did a microsystem survey questionnaire using the competing values framework, observational semi-structured interviews, very much a narrative storytelling methodology. So the approach throughout was a journey metaphor around what were the journeys of these hospitals? How did they get to where they were today? What were the events and the twists and the turns in their stories around quality improvement? Very much from the practitioner's perspective. As I say, in this original study, the Organising for Quality work, just looking at the meso and microsystem. This slide summarizes about 5 months' work, but we did all the field work. We produced narratives around the hospital's journeys. They were about 40 to 60 pages. We did some member checks. We fed them back to key informants in the participating hospitals. And then Peter, Paul, and I sat down and analysed those shared narratives and came up with what we felt were common challenges, solutions, and processes that combined to perhaps explain the improvement journeys in these hospitals. And from that, we came up with some general conclusions, practical lessons, and, as we said then, hypotheses for others to test. But in fact, we came back to test those hypotheses in the Quasar project. So this is what we came up with in terms of the common challenges that these leading, as that we'd been directed to them, healthcare organisations, acute hospitals, had all faced. And we presented them in this way using the colour code from Hans Vermark. Some of you may be familiar with it. So the challenges were structural challenges, political challenges, cultural challenges, educational challenges, emotional, and physical and technological. And then, as I say, we added a little bit of sort of context at the end, but we didn't really pay much attention. So just to give you an example, and I can't go through them all, but one of the challenges was around the structural challenge. How do these hospitals actually put in structures, processes, systems in place to manage their quality improvement effort? And what you see underneath the structural heading here is the types of solutions that we found across these hospitals. Now, of course, not all of the hospitals had used all of these solutions. They'd used different combinations of them. But these were the types of structural solutions that we seemed to be coming up against when we looked at our data. And similarly for the political challenge, the types of solutions that we found across the hospitals. And so we surmised in the book that if you lacked one or more, if you hadn't responded to or solved these universal challenges, then there were various outcomes for your quality improvement effort. So if you hadn't structured and planned and coordinated your quality improvement effort, that would result in fragmentation. If you hadn't engaged stakeholders, built good managerial clinical relationships, then that would lead to inertia, et cetera, et cetera. But in a way, they'd just taken us to where the research had been before in terms of coming up with that menu, the shopping list that Jean-Louis was referring to, a list of 6 things. But what could practitioners do with that? What we were really interested in was studying the interactions and the dynamics between these challenges and the solutions that the hospitals had used. And this is where I think we probably showed a bit of nerve. But we took Anne's challenge in her 1999 paper, and we took those narratives from the hospital case studies, and we decided we wanted to find out what were the combinations and connections that enabled these healthcare organizations to successfully implement, spread, and sustain quality initiatives. So what we did was to employ social network analysis techniques to examine and visualize, so visual mapping, one of the sense-making strategies, the patterns of relations amongst the processes for each of the case studies. So we took the 60-page narratives and we coded them using the challenges and the solutions as our coding framework. And we plugged them into some social network analysis to see what came out the other end. And this is what came out the other end. So this is the map for Cedars-Sinai. So this is looking at the sub-processes. This is looking at how all of the solutions that we found in Cedars-Sinai related to each other. And you see the colors there. So you see there's some yellow solutions linking to green educational solutions. And some of them, there'll be blue ones going to blue. So that's a structural solution feeding into another structural solution. So you've got in ties and you've got out ties in the normal way that you do when you do social network analysis. And when Peter Mendel, who did the social network analysis, first showed this to Paul and I, we sort of laughingly referred to this as the DNA of quality improvement. We'd found the double helix of quality improvement. We didn't know what it meant, but it looked good on the screen. The thing was, when you then aggregate up all of those various solutions and the interactions to the challenges, you begin to get a different picture in each of these hospitals about the way and the emphasis they've placed on the different challenges. So this is the Cedars-Sinai one. It's essentially the one you've just seen, but now aggregated up to the six common challenges. And what we found and so we have a map like this for all of the hospitals that took part in the original study. And what you find is that something's very common to all of the pictures that you see. I'm not going to have time to show them all to you, but it's this very strong cultural structural axis. You see this in all of the organizations. But what's different is the 3rd and 4th challenges, the ones that come out the most important in terms of the third and 4th in each of the hospitals. In this case, in Cedars-Sinai, around the educational challenge, and to a slightly less extent, the political one. But you see different patterns emerging in some of the other hospitals. So in Albany, where we were studying one of the first HIV clinics, I believe, in the US, you saw a much bigger emotional challenge. There was a much bigger response to the emotional challenge because of HIV treatment and care being seen as a social movement, as a mission, and not just a job for staff. In Peterborough, one of the UK sites, you'd see a much bigger circle for the political challenge because they'd worked much harder in terms of the relationships, for example, between clinicians and managers. So we did that first study. We wrote the book. We found out that some organizations were using it. We produced a sort of code book as a kind of heuristic reflective tool for organizations. We found out that some organizations were doing that. They were looking at what was going on in terms of their quality strategy in their organizations, and they were looking across these challenges and seeing which ones perhaps where the gaps were and where their strengths were, and then developing strategies on the back of that. Fellow researchers, academics use the kind of heuristic of the challenges in papers, in evaluations, but also in more sort of action research interventions. And then we kind of forgot about it because we were doing other stuff. And then this call came out from the European Union where they were willing to put €3 million into a study that looked at understanding the organizational and cultural factors influencing the implementation of quality improvement systems. And when we saw that, we thought, hold on, that's our organizing for quality study that we did on a shoestring a few years ago. So in collaboration with colleagues at King's College London, and the principal investigator for this study is Professor Naomi Fulop, we set about putting in a bid for this. We were successful. We wrote our protocol. If you want to see that, it's in BMC Health Service Research last year. And this had some very specific research aims. So to explore relationships between organizational and cultural characteristics of hospitals and how these impact on clinical effectiveness, patient safety, and patient experience in European countries. And very practically, the research objectives we were asked to meet by the funders to design and disseminate the quality and safety guide for hospitals to assist hospitals to implement quality and safety programs, and accompanying that, a similar guide for payers to assist purchasers of hospital services and government to assess quality of hospital care. Now, we can probably come back to in discussion to the wisdom of the idea that you can produce a single guide for every hospital across Europe to help them implement quality. We think it's much more around notions of guiding rather than a guide on a piece of paper. But that's a debate that we're having with the funders at the moment. But the key facts of this study: 3 years, €3 million budget, €3 million €3 million budget, 5 EU partners, project built around a series of interrelated work packages, very clear reporting lines and deliverables, with the same conceptual approach, starting with practice. What are people doing or not doing in terms of quality improvement at the hospital level and at the bedside? But this time we were building on the organising for quality work, so we explicitly started off with the six common challenges. And this time we also made sure that we did a much better job of finding the interactions between all three of the levels, between the macro, the meso, and the micro level perspective, and we gave equal weight to the macro level, the more contextual factors. And we've just finished the fieldworks. We now have case study narratives for each of the 10 hospitals that have taken part, 2 in each of the 5 countries. We have a meeting in 2 weeks in Stavanger in Norway, one of our partners, where we're going to sort of get our teeth into the cost case analysis, but the types of themes that are emerging early, at this early stage from the fieldwork, the very different ways in which quality is conceptualized at the macro, meso, and micro levels in each of the 5 countries. Issues around what role do national inspectorates play at meso and micro levels, again, very different. Is quality improvement a core or peripheral issue at those various levels? The big issue of context, clearly, how does the current financial crisis impact upon quality improvement in hospitals? Management-led, clinical-led, information about quality shared, how is quality improvement negotiated and enacted in hospitals, and where are the learning reflective spaces relating to quality improvement? These are very early days, and I'm sure we'll firm up on them when we're in Stavanger together. But the mantra for the project, and what we come back to whenever we meet, is interactions, interactions, interactions. We really want to get much closer at the dynamics and processes and relationships between these different processes that are going on in these hospitals. So just 2 examples of interactions between levels. So between the meso and the micro level, how do senior leaders manage the disconnected hierarchy? The use of issue sellers, of boundary spanners to bridge the gap between senior leadership level and clinical microsystems. And then one example of the meso-macro, how does senior hospital leadership enact their external environment? How do they use intermediary organisations, the media? How active or passive are they in trying to act back on that environment? But where we are is trying to produce what the European Union, our funders, would like is this guide, whatever that may look like. I'll use that for shorthand. And the place where we're at is, it takes us back, and again, this comes from Anne's 1999 paper, to Thorngate's work around in general versus it all depends. So any single method of data collection, in this case, is mainly qualitative. We have got some quantitative data from the later Quasar study, but it's mainly qualitative. You have to make trade-offs in the resulting theories: simplicity, generalizability, and accuracy. Because it's impossible for any theory of social organizational behavior to be simultaneously general, simple, and accurate for the reasons that I've listed on the slide. I won't go through them all. But of course, Carl White then goes on to suggest that the solution is not to search for a method that combines all 3 elements, but to build theory by alternating among sets of data that provide one or more of these elements, or by incorporating complementary research conducted by others. Oops, sorry, gone the way. So it takes us back again, and the title of this slide is the final sentence in Anne's 1999 paper. Let us make sense whatever way we can. We use visual mapping in the original Organising for Quality study. What we're interested in, and this has come out really of our experience of the field work, and this comes back to Van Manen's point, the refusal of communities to remain motionless before and after their portraits are sketched is a problem that has continued to plague field workers. And that's been a real problem in our study. So we picked these 5 high-performing organisations and these 5 low-performing organisations at the start of the study. And guess what? 12 months in most of the high-performing organisations, well, certainly in the UK, the chief execs left. There's been huge turnover around the senior leadership team. One of them has been visited by the accreditor and been given a warning, the Care Quality Commission. So what we're interested in doing now, this is why it's very timely to be spending time with Anne, is how do we analyse this data that's come out of this later study? And we're interested not in using the visual mapping approach, although we may come back to that later, but to use this sense of this notion of temporal bracketing. So we begin with our narratives, and again, we've got sort of 60, 80 pages narratives for each of these 10 hospitals. they're multi-level case studies, they've used an agreed framework, the organising quality framework. So the initial step in the sense-making process is to have those narratives. We then use those to identify phases across the 10 case studies. Where are each of the hospitals on their quality journey and how did they get there? Including phases in which they've regressed, and those are the types of issues that we're finding in our fieldwork. From that, formulate hypotheses and propositions relating to organisational processes, and importantly, how context affects those processes for the guides or whatever the guides may become. So I think we've kind of stumbled, and this wasn't really by design, but we've kind of stumbled on putting these two studies together in terms of going into the field in the original organising for quality work, very open-minded, being driven very much by the data, very inductive. Then moving to the Quasar study, much more theory-driven, using the original organising for quality work, testing those hypotheses. And we're now at the stage of trying to think creatively and bringing insight to bear on all the data that we have. This is the penultimate slide, and this goes to the point that Jean-Louis made at the end of his introduction. That's all very well, but we also need to think about how are we going to transfer the knowledge from these guides, whatever form they might be in, on a large scale into hospitals in Europe. So the next project grant, the next proposal, is to find ways of providing evidence about how practical lessons from rigorous and robust quality improvement research, such as that we've undertaken, can be implemented on a large scale to improve the quality of healthcare in European hospitals. So what we're looking at is conducting an evaluation, and I think importantly in the current context, a cost-consequences analysis of different knowledge translation interventions in order to provide generalizable lessons pertaining to the translation of research findings into healthcare practice, with the aim of increasing understanding of organizational processes by which research findings are implemented. So I hope that's given you a sense of these two studies and how they seem to be coming together, although, as you'll have seen from the table comparing them, they are quite different in lots of respects. But I think our approach has been very much around this notion of trying to get to actionable knowledge. And Paul Bate, my colleague, who was involved in the original study, used this phrase around being honest grapplers. When you're trying to fill this space between academic research and practice, and you're trying to bend the two ends of that continuum, so you're getting research into practice, there is something about being an honest grappler and just trying things out. And I think we've tried to display some nerve, at least in some of our methods and ways of analysis. But I wanted to end with the final word from John van Manen, who says, fieldwork is messy, conflict-ridden, and always problematic. And then this really nice quote at the end: accident and happenstance shapes fieldworker studies as much as planning or foresight, numbing routine as much as living theatre, impulse as much as rational choice, mistaken judgments as much as accurate ones. This may not be the way fieldwork is reported, but it is the way it's done. And I think the relevant point is that's also the way that quality improvement is implemented. This may not be the way quality improvement is reported, but it is the way that it's done. Thank you very much.